All right, so I'm gonna be talking about hemodynamics, and I believe this is second and third year residents, right? So
Yes.
hopefully everyone will find this interesting. As you know, this is a huge topic and there's a lot to cover, but I'm gonna try to hit the highlights and, hopefully have some time to discuss cases and leave some time for questions as well. I do have some extra slides. If anybody is interested, we can discuss those in detail if we have time left, or I'm happy to discuss them offline with whoever's interested as well. So I'm going to go over some basics, normal pressures and abnormalities, outputs and vascular resistance, and then hemodynamic guided therapy along with some cases. Coming to the basics first. So this is, the essential equipment that's needed for a right heart catheterization. It can be done in the cath lab, it can be done bedside in the CCU as well. So this is what a swan looks like. Hopefully everybody's seen what a swan looks like if you've rotated in the CCU or had a chance to go to the cath lab. It is about 100 centimeters long, has a balloon at one tip. There's a thermal filament, which is used for thermodilution cardiac output measurements. And we'll discuss that a little later as well. Then, as you can see, the swan has multiple lumens, and each of these lumens eventually can be connected to a port. So the blue one is generally the CVP port. The yellow one is generally the PA port. Some swans might have a port in the right ventricle as well. And then there's two ports to connect to the thermodilution thermistor connector. And then in some type of swans, there can be an optical module to connect for measuring the mixed venous oxygen as well. I won't go over the procedure in too much detail, but essentially access can be obtained in the right IJ, right femoral vein, or in the right, either right or left, or in the antecubital vein. We typically do it from the right IJ because it's the most straightforward access. The right internal jugular is directly connected to the SVC, but any site can be used to access. This is the swan's ports will be connected to a pressure transducer, which is how the numbers, which is how the pressure readings are, displayed to us. And essentially how that works is, each of the ports is connected to a pressure transducer. So for instance, the blue would be connected to the, CVP port, the yellow would be connected to the PA port. And what the transducer is a fluid-filled chamber, and the catheter is also filled with fluid. So the pressure changes that are occurring in the heart are relayed through this fluid-filled catheter, and those pressure and based on the pressure, the fluid level keeps changing, and that is displayed in the form of an electrical waveform. After a swan is placed, or when you're doing a right heart catheterization under fluoroscopy, you want to make sure that the swan is in the correct position. So when the swan is in the wedge position or in the distal PA, we want it to be in the third zone over here. That is at the bottom of the lungs, in the lower fields of the lungs, where the arterial pressure is going to be greater than the pressure in the alveoli of the lungs. And what that will look like on X-ray is that the tip of the swan should be about 3 to 5 centimeters from the midline. If the swan is in too deep, so for instance, in the second picture over here, you can see that the swan is in really deep. If you saw something like this on an X-ray, that should point you towards that the swan needs to be pulled back because it's in too deep. So the primary indications for a pulmonary arterial catheterization or right heart catheterization, what we call this, a picture of Dr. William Gans and Dr. Swan, who first devised this. Essentially what they did was they took a Foley catheter, put a balloon at the tip, and realized that they could float this in the heart and get pressure measurements from the intracardiac chambers. The primary indications really are any unclear hemodynamic picture where you're unsure of the volume status, unsure of the cardiac output, pulmonary arterial hypertension, as well as consideration for advanced therapies for heart failure. And then certain other conditions where right heart catheterization may be helpful as well, cardiogenic shock, especially complicating acute MI. You want to have accurate hemodynamics to help with measurements. mechanical complications, as well as a ventricular septal rupture, where it can help you with shunt evaluation, valvular heart disease, congenital heart diseases, complications of transplanted heart, where you might want to perform a right heart catheterization along with a biopsy, depending on the situation, pericardial diseases, as well as perioperative management for patients with a cardiomyopathy or other cardiac conditions going for non-cardiac surgeries. So a lot of conditions where right heart catheterization may be helpful. Primarily at the bedside, though, you're going to be using it to manage patients who have an unclear hemodynamic picture, or pulmonary hypertension, or patients you're considering for advanced therapies. And several years ago, there was data from the ESCAPE trial, which really made it seem like right heart catheterization does not have any impact on mortality. But that was a very flawed study in the sense that there were all kinds of shock that were in that study. 50% of those patients actually had septic shock. So while it is true that a right heart catheterization is not helpful for every single patient in shock, meaning routine use is not recommended, there is a subset of patients in shock, especially cardiogenic shock, where a right heart catheterization is very useful. And it has been shown that complete hemodynamic profiling with pulmonary arterial catheters in cardiogenic shock is associated with lower in-hospital mortality. So this was a study where, this is a retrospective study. In blue, you can see these are patients who did not have any hemodynamics obtained. Red patients had incomplete assessment, and in gray patients had complete assessment. And it's really sad to see that only 40% of patients had complete assessment. So majority of the patients either had no or incomplete assessment in cardiogenic shock. But in the overall cohort, there is a lower mortality associated with complete hemodynamic assessment, as you can see in the first graph. And even in advanced stages of shock, which are stage D and stage E, even in those advanced stages, using a pulmonary arterial catheter and obtaining complete hemodynamics did offer a mortality benefit. Coming to the hemodynamic principles of right heart catheterization, essentially what we're trying to do with measuring pressures is get an indication of what the volumes of the heart chambers are like. How we get that is based on the pressure volume loop. I won't go into that in much detail, but say you start at point A, that's the beginning of systole. The first phase is isovolumic contraction, then is ejection. This is end systole. Then diastole starts, isovolumic relaxation, and then filling. And this cardiac cycle is very important to remember as we go forward and discuss the pressures and waveforms. A couple of things to remember is that pressure is only a surrogate for volume, and it may not, just because there's an increase in pressure does not always mean that there's an increase in volume. So for instance, especially in patients with heart failure with preserved ejection fraction, where they have increased stiffness, meaning the normal end diastolic pressure volume relationship, which normally is over here, and the dotted line represents the change in heart failure with preserved EF. So you can see even for a given volume, the pressure is much higher in patients with heart failure with preserved ejection fraction. The other important thing to remember is that hemodynamics change over time. So even a few hours after performing the right heart catheterization, there can be changes in the hemodynamics that you obtained. So if you just do it once, you're only getting a snapshot. And if it's really needed, for instance, in certain patients with cardiogenic shock, an indwelling PA catheter can really help guide management because you're getting real-time views or real-time information about the hemodynamics. So coming to normal pressures and abnormalities in pressure readings, first we'll start with the right atrial pressure. So right atrial waveform has 5 components. The first is the A wave. The A wave represents the atrium contracting with the tricuspid valve open. So this follows the P wave on your EKG. The C wave, that's in the down slope over here, that represents the closure of the tricuspid valve. So there's a little bulge into the atrium, and that is represented as a slight increase in the pressure. Then is the X descent, that is the relaxation of the right atrium. and the downward pulling of the tricuspid annulus by RV contraction. So when the X descent is happening, the LV is in diastole at that time and filling up. Then is the V wave, which represents the RV contraction or ventricular systole. And at the same time, there is venous refilling of the atrium. And then finally, the Y descent, when the tricuspid valve opens and the RA starts emptying into the RV again. Normal changes in the RA pressure with respiration. During inhalation, the intrathoracic pressure falls, and that's translated into the RA pressure falling. So as you can see over here, the RA pressure starts decreasing in inspiration, and in exhalation, the reverse happens, where the intrathoracic pressure increases, and that's translated into the RA pressure increasing. So this is a normal respiratory variation that we see. And the normal RA pressure is 0 to 6 millimeters of mercury. Coming to abnormalities in RA tracing, the RA pressure can be low in cases of hypovolemia and elevated in several disease states, particularly RV failure, which can again be due to valvular diseases of the right-sided valves or myocardial disease from either non-ischemic myopathy or ischemic cardiomyopathy, or just left-sided heart disease as well due to left-sided valvular heart disease or left ventricular failure. RA pressure can be elevated when you have increased pulmonary vascular resistance, either from PAH or PE, COPD, sleep apnea, elevated as well as in tamponade and atrial myxomas. Certain other abnormalities in the waveform, and these abnormalities are really going to highlight the importance of looking at the actual waveforms, not the numbers, because the waveforms itself can give you a lot of information of what's going on in the heart. So A wave, as you can remember, represents the atrial contraction. You'll get a Canon A wave when the atrium is contracting against a closed tricuspid valve. Normally, the atrium is contracting against an open tricuspid valve. So conditions in which you would see that would be when there's AV synchrony, like in complete heart block. You'll get an absent A wave in atrial fibrillation. As you remember, again, A wave represents the atrial contraction. In atrial fibrillation, there's no real atrial contractions happening. Elevated V waves, which normally would happen in ventricular systole when the tricuspid valve is closed. You'll get a big V wave when you have TR because the tricuspid valve is, instead of being closed, it's open and there's blood flowing backwards into the atrium. And in RV failure as well, similar physiology, essentially there's blood flowing backwards in RV failure because the blood is not flowing forward. Prominent X descent can be seen in tamponade as well as RV ischemia. In these conditions, there's a rapid early filling, and after that, the filling stops because of increased pressure. Like in tamponade, that's pressure that's externally. In RV ischemia, it's because the RV becomes non-compliant. Prominent Y descent can be seen in constrictive pericarditis, again because of the rapid emptying of the atrium and the restricted filling because of the pericardial constraint. Blunted Y descent can be seen in RV ischemia and tamponade as well. Again, these are, it's a pretty big list of things that can cause abnormalities, but the point is really to understand the physiology of these waves and what abnormalities, you would get in what condition. More so to recognize, what that something is abnormal and to get a sense of what could be causing it. So Kussmaul's sign, Kussmaul's sign represents inspiratory rise or lack of decline in RA pressure during inspiration. Normally, like we talked about, in inspiration, the RA pressure falls. In conditions like tamponade or constrictive pericarditis or RV ischemia, instead of the RA pressure decreasing in inspiration, there can either be a lack of decrease or an inspiratory increase, like you see over here. You can see during inspiration, the RA pressure really increases, and there's a big dramatic increase in the V wave, especially in the A waves, especially. Can anyone highlight the abnormality over here? The green represents a respirometer, so it's telling you that the patient is inspiring and breathing out. Does anyone want to take a guess? What you're seeing over here is that there's no change with inspiration in your RA pressure, right? We just talked about that normally you should see a decrease in your RA pressure with inspiration, and here you're not seeing that. So this kind of physiology you would get in all conditions except.
Anyone care to answer this or guess this? I know we've some budding cardiologists here.
Yeah. So that's a good thought, but we just discussed that you would get Kussmaul sign, for example, right? Kussmaul sign, this is what we're seeing here is Kussmaul sign. You're not seeing a decrease in the RA pressure with inspiration, right?
Transplant? Transplantation?
You could actually see that in transplantation also. So this would be consistent with all of these except for tamponade. Because in tamponade, you have fluid around the heart. The pericardial pressure exceeds the pressure inside the cardiac chambers, particularly on the right side, and the respiratory changes are not communicated with the intracardiac pressure changes. Normally, the pressures in the right side of the heart decrease because of the intrathoracic pressures being relayed to the right side of the heart. But in tamponade, these pressures are not relayed to the right side of the heart. So here we're seeing huge V waves, right? Anyone can guess what this condition would be?
Could be mitral regurgitation.
Yes, we're on the right side of the heart, so it would be tricuspid regurgitation.
Sorry.
Tricuspid regurgitation. And what this kind of waveform is called is a ventricularized CVP. So it looks like, almost like a ventricular tracing where you have a systole and diastole. So it's called a ventricularized CVP, which you could see in severe TR or severe RV failure as well. And again, highlights the importance of actually looking at the waveform. If you just look at the mean number, it's probably 17 or so. But that doesn't give you as much information as actually looking at the waveform and seeing these huge V waves.
Sorry, is there any chance we can go back to the first case?
This one?
Yeah, so we're seeing an absence of the variation of the with respiration. And then we see that in all of the other cases. Going to the question again.
Yes.
But in constriction, restriction, transplantation, RV infarction, there is no variation with respiration. Is that what you're saying?
Yes. In transplantation also, you can see that because you get a restrictive physiology, there's myocardial edema, and the RV doesn't relax as well.
But we see variation with tamponade?
You would see in tamponade, you would see an exaggerated variation, yes.
Okay, that makes sense. Okay.
Dr. Singhvi, this is Brett. Why would we see an exaggerated variation? Because it's a closed compartment, like based on the Pascal's law, it should be equal pressure in all the chambers. Like, why do we get exaggerated variation of the RA waveform? So
that happens basically because with inspiration, you have an increased venous return. And so so there's a couple of components. It's because one, it's because of the increased venous return on the right side, but the RV is not able to expand to be able to handle the increased venous return with inspiration. So that's reflected as an increase in RA pressure. In addition, the RV and LV are filling at the expense of each other. So both of these will translate into exaggeration of the respiratory variations.
Isn't this also happening in constriction? Same physiology?
In constriction, again, you could see it really depends on how advanced the disease is as well. Sometimes what you would actually get is because in constriction, because of the thickened pericardium, the respiratory changes are not transmitted to the right side of the heart. And there's also variation, there's also filling of the RV at the expense of the LV. And the RV filling is fixed essentially in constriction. So the respiratory changes may not be translated. So what you were talking about was equalization of the pressures in tamponade as well, equalization of the diastolic pressures in tamponade. And this is just, these are just waveforms to kind of highlight that here. It may be a little difficult to tell, but over here you're seeing the RA waveform at the bottom, and then you're seeing the LV, you're just seeing the bottom half of the LV waveforms. And you can see that the LV diastolic pressure and the RA pressure over here are equal. The RV and LV diastolic pressures are also equal, and the permicapillary wedge pressure and the LV and diastolic pressures are also pretty equal. Coming to the RV, so in an RV waveform, you're going to see a systolic component and the diastolic component. The systolic component is going to consist of isovolumetric contraction followed by ejection, which is this upstroke that we're seeing over here. And the diastolic component is going to have isovolumetric relaxation. And after the tricuspid valve opens, this is the diastolic part. And after the tricuspid valve opens, then you'll see filling. And in the filling phase, there's an early rapid phase and slow phase, and then the atrial contraction. So just to go over things, this is the isovolumic contraction that you see first, then the ejection, then the isovolumetric relaxation, and the filling phase. This is the early rapid phase, the slow phase of diastolic filling, and then the atrial contraction, which is the A wave in the RA waveform. And the normal systolic pressure is 15 to 25. Normal diastolic pressure should be the same as your RA pressure, which is 0 to 5.
Is it to change it to 20 now, or still 25?
Sorry?
I think they were saying like it's to 20, and
that's the mean PA pressure.
Yeah.
The PA systolic and the RV systolic would be equal. It's the mean PA pressure, you're correct. The mean PA pressure now, the cutoff is less than 20. Certain abnormalities that you can see in the RV tracing is the dip and plateau waveform. So the dip represents early rapid filling, which is exaggerated, and plateau because the filling during the slow phase of diastole and in the later part of diastole is restricted. And that can be seen in constrictive pericarditis, restrictive cardiomyopathy, and RV ischemia. So, we just talked about constriction and restriction. So the dip and plateau is going to be seen in both of them. This is an important distinguishing feature between constrictive pericarditis and restrictive cardiomyopathy is the presence of RV and LV interdependence. In constrictive pericarditis, one chamber has to fill at the expense of the other chamber. So with inspiration and expiration, you'll see changes in the LV and RV filling at the expense of each other. So you can see during inspiration, when the venous preload increases or the venous return to the heart increases, the RV pressure increases. But because the septum has to shift, because the RV cannot, expand outwards to accommodate that increased volume, it fills. The septum has to shift into the LV, which means that the RV has to fill at the expense of the LV. So you'll see pressure in the LV decreasing during inspiration, and then in expiration, the RV pressure decreases and the LV pressure increases. So this is called LV and RV interdependence. In restrictive cardiomyopathy, the same type of pericardial constraint does not exist. So when the RV pressure increases, so does the LV pressure, and when the RV pressure decreases, so does the LV pressure. So they decrease concordantly and increase concordantly. Coming to the pulmonary artery pressure, normal systolic pressure is 15 to 25, diastolic pressure is 8 to 15, and the mean PA pressure is 10 to 20. Again, this is an arterial waveform, so it's going to be biphasic. You'll see a systole and diastole. Mild pulmonary hypertension is a mean PA pressure that's greater than 20. Abnormalities in PA tracing. Elevated systolic pressure you'll see in primary pulmonary hypertension, also left-sided heart diseases and other cardiomyopathies, pulmonary diseases, left-to-right shunts. And a reduced pulmonary artery pressure can be seen in hypotension, pulmonary artery stenosis or pulmonic stenosis, Epstein's anomaly, tricuspid stenosis, tricuspid atresia. Reduced pulmonary arterial pulse pressure, that means the pulsatility of the pulmonary artery, the PA systolic minus the PA diastolic, you'll see in RV, basically severe right ventricular failure. So right ventricular infarction, right heart ischemia, acute pulmonary embolism, and tamponade. And normally the PA diastolic and the pulmonary capillary wedge pressure should be relatively similar, but you'll see the pulmonary arterial diastolic pressure greater than a wedge pressure in pulmonary arterial hypertension, acute PE, and even in tachycardia. Coming to the pulmonary capillary wedge pressure, mean PCWP is about 6 to 12 millimeters mercury, and this is a venous waveform. So the waveforms that you see, the A wave, the C wave, V wave, X and Y descent, they're basically analogous to the CVP waveform. So first you see, for the first wave you'll see is the A wave, which represents the left atrial systole. C wave represents the protrusion of mitral valve into the left atrium. Then the X wave is the relaxation of the left atrium. V wave represents LV contraction. And generally in the pulmonary capillary wedge pressure, this is higher than the A wave, as opposed to a CVP where the A wave is higher than the V wave. And then the Y descent, which represents the opening of the mitral valve and the LA emptying into the left ventricle. And again, you'll see in the wedge pressure also, there's normally a variation with inspiration. With inspiration, the pressure will decrease, and with expiration, it will increase. It's very important to make sure that when you're obtaining a wedge pressure, that the balloon is properly wedged. The way this is done is that the pulmonary arterial catheter is advanced into the main PA with the balloon inflated. And then you'll see that when you're wedged, the balloon will essentially get stuck. So you're going to be wedged in one of the smaller pulmonary arterioles or the capillaries. And because the balloon is occluded, the pressure that the tip of the catheter is going to be sensing is the pressure in the pulmonary capillaries. So this is a proper wedge where you're going to be seeing appropriate A and B waves. When you're over wedged, that means that you're very distal. You're going to see the pressure suddenly jump up and increase. You're not going to have proper A waves and B waves. It means that there's overinflation of the balloon. If your catheter is too distal, there's going to be damping of the tracing. And if with the balloon down, that means the balloon deflated, the catheter wedges, that means you're probably very distal as well. So, when we're measuring a pulmonary capillary wedge pressure, there's a couple of things that we're trying to see. We're using this as a surrogate for the left atrial pressure or the left ventricular end diastolic pressure. When the mitral valve is closed, that means in systole, the pulmonary capillary wedge pressure represents left atrial pressure. But when the mitral valve is open, the pulmonary capillary wedge pressure represents the left ventricular end diastolic pressure. So it's important to remember that it approximates the LA tracing, but it's slightly delayed because the pressure wave that you get in the pulmonary capillaries is transmitted retrograde. So you can see if you have two simultaneous catheter, one in the LA and in the wedge position, that the wedge waveform is slightly delayed from the left atrial waveform. Normally, the LA pressure is also slightly higher than the RA pressure, but if you have significant RV failure, pulmonary hypertension, in those conditions, the RA pressure can be greater than the wedge pressure. And it's been shown that, CVP is generally, the wedge pressure is generally twice of the CVP. So you can see a very good relationship most of the times. This holds true. So if you're seeing a CVP that is, more than half the wedge pressure, essentially, that should alert you into thinking that there's significant RV failure or something along those lines, out of proportion to the left-sided heart disease. And normally the PA systolic is also twice the wedge pressure. And if you're seeing a PS systolic that is much greater than the wedge pressure, that should alert you to thinking that you have some pulmonary vascular disease like PAH or acute PE. Abnormalities in the wedge pressure, again, you're going to have an increase in the pulmonary capillary wedge pressure if you have left-sided heart failure, either from valvular diseases or any kind of myocardial disease, diffusion, atrial myxoma. Elevated V waves, this is analogous to the V waves that we have on the RAs. In the RA side, you'll see an elevated V wave if you have severe MR or severe LV failure, ventricular septal defect. Sometimes you'll see a dramatic change in the wedge pressure with exercise, and that's essentially diagnostic for HFpEF. So you can see at baseline in this patient, the wedge pressure looks normal, and with exercise, you can see huge V waves that represents either there's dynamic MR or there's advanced diastolic dysfunction. The left atrium is very stiff. So with exercise, you'll see a big increase in the wedge pressure. Certain conditions in which the wedge pressure is not going to be equal to the LV end diastolic pressure, mitral stenosis, basically conditions in which you have some sort of an obstruction in between the two. So mitral stenosis, atrial myxoma, core triatriatum, and pulmonary venous obstruction. Coming to left heart catheterization, this is not something that you're really going to be doing at the bedside, but in certain conditions, you're going to be doing a left heart catheterization in the cath lab to diagnose certain conditions. Generally, we use it for left-sided valvular heart disease. And it's analogous to the right heart catheterization, meaning you just have a catheter in the left side of the heart. And typically, we use a pigtail catheter to measure pressures in the left side of the heart. So the left side, left ventricular pressure tracing, you're going to have a biphasic waveform consisting of the systole and diastole. Just like we talked about on the right side, systole first part is the isovolumetric contraction, then the ejection phase, and the diastole consists of isovolumetric relaxation followed by filling. And here's both a pulmonary capillary wedge pressure tracing along with the left ventricular tracing, and just to show you the wedge and the relationship between the wedge and the LV diastolic pressure. You can see that early on in diastole, the wedge pressure is actually higher than the LV pressure. It's basically at the end of the LV diastolic filling when the wedge pressure and LV EDP are similar. And again, this relationship changes with inspiration and expiration as well. Normally with inspiration, you'll see a slight decrease in the difference between the two pressures, and with expiration, you'll see an increase in the difference between the two pressures. So certain conditions where it might be helpful to measure pressures in the left ventricular and aortic and aorta simultaneously. This is the normal relationship between the aortic pressure tracing and the left ventricular tracing. You can see this is the end of diastole. This is the beginning of isovolumetric contraction. Then the aortic valve opens and systole begins. The LV systolic pressure will drop all the way almost to zero in diastole. And the way you know that this is an aortic pressure tracing is because in diastole, the pressure does not drop to zero, right? So even in diastole, you're going to have a pressure of about 80 or so in the aorta. And then when the aortic pressure exceeds the LV pressure, the aortic valve will close, and so on and so forth. Comparison between the RV and the LV pressure tracings, generally the diastolic amplitude is similar. The systole is obviously higher in the LV compared to the RV. The LV systolic pressure is in the range of around 120. The RV systolic pressure is in the range of 20 or so. The duration of systole, isovolumetric contraction, and isovolumetric relaxation are generally longer for the RV, and the duration of ejection is shorter for the LV than the RV because of the higher pressures generated. Some abnormalities in the LV tracing. So here we're seeing the LV tracing and the aortic tracing overlaid on it as well. Can anyone guess what this is?
Aortic stenosis.
Right, so this is severe aortic stenosis. Normally your aortic systolic pressure in the aorta and the LV systolic pressure should be the same. Here you're seeing that the aortic systolic pressure is much lower than the LV systolic pressure. So you're correct, that's aortic stenosis. Another important thing to remember in this this can be important when you have catheters in the peripheral arteries and the central aorta. The peripheral arterial tracing is generally a little later and a little higher than the central aortic pressure tracing. And that's because of the propagation along the peripheries. Some abnormalities that you can see in the central aortic pressure tracing. Here you can see that there are 2 notches in systole. This is called pulsus disferiens. Right? What do we see this in? So you could see this in hypertrophic obstructive cardiomyopathy and aortic insufficiency. Here you can see that every other beat is smaller, right? This is called pulsus alternans. You could see this in tamponade, advanced cardiomyopathy. Okay. And here we're seeing, anyone can explain what we're seeing over here? So you can see that it seems like the aortic pressure is increasing and then decreases, increases and then decreases.
This is like arrhythmia or AV dissociation?
So that wouldn't affect the AV dissociation, would not impact the peripheral arterial pressure, right?
Mm.
So we're not seeing in pulsus alternans, you saw every other beat was higher and every other beat was smaller. Here it's more periodic. So the pressure increases and the pressure decreases. This is called pulsus paradoxus. Right? What do we see pulsus paradoxus in? Cardiac tamponade. Right? So these are normal reference values, which we went over while discussing the individual pressures. Let's go over a few cases. So this is a 76-year-old woman coming to you with shortness of breath and pulmonary edema. Blood pressure is 280 on admission. With treatment, her pulmonary edema resolves and the patient is stable. For which of the following is a right heart catheterization indication? Routine management of pulmonary edema, even if endotracheal intubation and mechanical ventilation has been necessary. To differentiate from cardiogenic versus non-cardiogenic before a trial of intravascular volume, or to treat patients with marked hemodynamic instability in whom tamponade is probable by echo criteria. To be used in the perioperative management of patients with compensated heart failure. Compensated heart failure undergoing low-risk non-cardiac surgeries, or to facilitate titration of diuretic vasodilator or inotropic therapy in patients with severe heart failure.
So people, you can post in the chat like your A, B, C, D, E, if anyone wants to either unmute yourself and give your reasoning. I see Jose Aguilar picked option B, differentiating cardiogenic and non-cardiogenic shock.
Yeah, if you really think this is undifferentiated shock, that's not unreasonable. But if you really think somebody needs volume, you don't generally need a right heart catheterization for that.
So I see most people now, and the most popular answer is option E, Subrat or Niru, if you want to maybe kind of go through your reasoning for picking that one.
So I think the classical teaching is when we have a discrepancy in the clinical findings and what we are expecting when we are giving a particular drug. Like for example, the JVP is not raised, and you still think that patient may be volume overloaded, and so we try to get more invasive to to kind of monitor to kind of direct our diuretics and vasodilators.
Right. Yes, right. You're right. You know, B and E are a little confusing, but the point that I was trying to make is that generally, you know, if you're doing a right heart catheterization, it should be to guide inotropic therapy or pressors, you know, those kind of things. And especially if you're thinking that somebody has advanced heart failure and you're trying to evaluate them for advanced therapies, that's when you would, you know, that's when a right heart catheterization would be helpful. Next case, you have a 48-year-old male with edema, ascites, dyspnea for 6 months, fatigue for 2 years. His heart rate is 95, blood pressure is 105 without a pulsus paradoxus. And we talked about how you can see pulsus paradoxus in tamponade. Right, JVP is elevated, first and second heart sounds are normal. There's an early diastolic sound at the apex. Lungs are clear, there's ascites, severe peripheral edema, cardiomegaly, some pleural effusions, creatinine is a little elevated, alk phos and bilia are elevated. EKG shows some non-specific T-wave changes. Echo shows a normal LV size and function, and there's abnormal septal motion, and angiography is normal. So what you're really seeing is right-sided heart failure signs, right? Elevated JVP, ascites, edema. There's probably cardiorenal syndrome from elevated venous pressures and probably congestive hepatopathy. So you take the patient to the cath lab, and this is what you see. Here are the arterial, the capillary wedge pressure and the LV tracings during inspiration and expiration. And here are the RV and LV tracings during inspiration and expiration. So which of these is the most likely explanation for these findings? Does anyone want to talk about what we're seeing here?
So Frida has said option B. Also, I see Andrew saying maybe it's ventricular interdependence. Frida and Fatima. Yes.
Right. So what we're seeing over here is that with inspiration, when the RV pressure increases, the LV pressure decreases. And conversely, when the RV pressure decreases, the LV pressure increases. So that's LV or RV ventricular interdependence. The pressures are discordant, and you would see that in constrictive pericarditis. Next case, you have an obese 30-year-old woman with a murmur. She's referred to you for an evaluation. Echo is interpreted as AS, but it's poor quality. On your exam, she has a systolic ejection murmur. And cath is performed, and this is what you see when you do a pullback. Pullback meaning your catheter is initially in the LV and that you pull it back into the aorta. So which of these do you think she has?
Hypertrophic cardiomyopathy with obstruction.
Right. So she has essentially, as you're pulling the catheter back, you can see a pressure gradient in the LVOT, right? And this kind of notch that you see also tells you that there's an LVOT gradient, okay? As opposed to aortic stenosis, where you would see that the pressure in the LV is the same, and then it decreases when you go to the aorta. Here you're seeing as you're pulling back, meaning over here, it looks like you're probably in the LVOT. That's when you start seeing the drop in pressure along with this notching in the systole. So that's seen with an LVOT gradient. It's, yeah, B and C are basically the same thing, so I apologize for that. You know, coming really quickly to the last part, outputs and vascular resistance. So cardiac output is the quantity of blood delivered to the systemic circulation per unit of time. There are two methods basically that we can use during a right heart catheterization to gauge the cardiac output. Sorry, the first is the Fick method, and the second is the indicator dilution method, which can either be using a dye or a thermodilution. I'm going to go really quickly over them. Essentially, you know, the point is really to understand the principles with which the principles that we use to calculate these outputs. So the Fick principle basically says that the total uptake or release of any substance by an organ is the product of the blood flow to that organ and the AV difference in the concentration of that substance. So meaning that the amount of blood flow that you get to an amount of, so cardiac output is the amount of blood flow going to a particular organ, and the only organs that get 100% of the cardiac output are the heart and the lungs, right? So we use the heart, so in the Fick principle, we're using the lungs essentially, and the substance that is taken up by the lungs that we're using is oxygen, right? So as applied to the lungs, that substance is oxygen. And what this Fick principle translates into is that the oxygen consumption will be equal to the oxygen delivery times the oxygen extraction by the body. So rearranging that, we get cardiac output equals oxygen consumption. That's VO2 divided by the AVO2 difference. Okay, and in the absence of any shunt, QP, meaning the blood flow to the heart, blood flow to the lungs, is going to be equal to QS. That's the systemic cardiac output. So the pulmonary arterial cardiac output and the pulmonary cardiac output and the systemic cardiac output are going to be the same in the absence of a shunt. So we assume that the cardiac output is equal to QP that we're calculating. So essentially, for most cases in the cath lab, we use an assumed oxygen consumption. The assumed oxygen consumption is a constant that we use, and for calculating cardiac index, the oxygen consumption that we use is 125. So that's already divided by the BSA. But again, this is an assumed oxygen consumption, which has its limits. If you really want to be get more accurate measurements, and then there are normograms based on height and weight and age and sex that you should use to calculate the oxygen consumption. But again, those are assumed oxygen consumptions, because in disease states, for example, when you have someone with heart failure or anemia, their oxygen consumption is not going to be the same as somebody who has, who's normal, has no medical illnesses essentially. So the most accurate way to measure oxygen consumption would be to actually have a respirometer on a person and measure their oxygen consumption, which is what we do in cardiopulmonary exercise testing. So the reason cardiopulmonary exercise testing is so prognostic is because you can see the cardiac output and oxygen consumption have a linear relationship for any given AVO2 difference. So AVO2 difference is basically the difference in the arterial concentration of oxygen minus the difference in venous concentration. So first step, we use the oxygen carrying capacity of the blood, which is 1.36 per gram hemoglobin. Then we determine the arterial oxygen consumption, which is the arterial saturation, times oxygen carrying capacity. Then we determine the mixed venous oxygen saturation times oxygen carrying capacity. The mixed venous oxygen saturation that is the most accurate, which will be the pulmonary arterial saturation, because that represents blood from both the IVC and SVC. And as you know, the saturations in the SVC and IVC are slightly different. And so the AVO2 difference will be the arterial oxygen content minus the mixed venous oxygen content. So like I mentioned before, if you're using an assumed oxygen consumption of 125, that goes in the numerator. AVO2 difference, for somebody with an arterial sat of 99% and a mixed venous sat of 75% would basically be 0.99 minus 0.75 times, say their hemoglobin is 14, times the oxygen carrying capacity of blood, which is 1.36 mLs of oxygen per gram of hemoglobin, times 10 to convert deciliter and liter. So if you use these numbers, you'll get a cardiac output of 5.4, which is a normal cardiac output. And you can see if somebody has a much lower venous oxygen saturation, then the denominator is going to be larger and the cardiac output is going to be lower. The indicator dilution method uses a slightly different way of calculating the cardiac output, but is a similar principle. So the bolus of, basically what is done is that the bolus of an indicator substance mixes with the blood, and then we measure the concentration of that substance. And the concentration of that substance over time will tell us how much blood is flowing. And you can either use a dye, or in thermodilution method, we use cold temperature. So we'll essentially what you get are graphs sort of like this. The red is a normal graph, which is telling you the temperature change over time. And depending on how fast or slow the blood is flowing, the temperature change will be faster or slower, right? So if you have a low cardiac output, the temperature change is going to be much slower. And this is a complicated calculation, which the computer generally does automatically for you. Basically, in the numerator, you're going to have the change in the temperature. And in the denominator, it's going to be an integration of how fast that change is happening. Both, having a low cardiac output does have a prognostic value as well. But in comparisons of both the FIC and thermodilution cardiac output, the thermodilution cardiac output has been shown to be more prognostic for reasons that are not entirely clear, but it may partly be related to the fact that in most centers for FIC cardiac output, we're using an assumed oxygen consumption as opposed to an actual oxygen consumption. So you can see at 1 year, if both are normal, you have the lowest mortality. If both are low, you have the highest mortality. But out of FIC and thermodilution, if your FIC is normal, but your thermodilution is low, you have a worse mortality as opposed to the other way around. Going over really quickly over vascular resistance, we calculate vascular resistance using Ohm's law. So Ohm's law tells you that voltage equals flow times resistance. So in the case of, systemic or pulmonary vascular resistance, the voltage is the blood pressure and the flow is the cardiac output. So for SVR, just rearranging this equation, you get SVR equals the mean arterial blood pressure minus the mean CVP divided by the cardiac output. For the pulmonary vascular resistance, for the pulmonary vascular resistance, it's mean PA pressure minus the wedge pressure divided by cardiac output. These are normal values. Typically, we present SVR in dynes, second per centimeter to the power of 5, and it's 800 to 1200. If your SVR is low, means you're vasodilated. SVR is high, means you're vasoconstricted. Normal PVR is expressed in Wood's unit, and that's derived by dividing dynes second divided by centimeter to the power of 5 by 80. So normally PVR is between 1 to 3 Wood's units. I think I'll skip this. Coming to the definition of pulmonary hypertension, as we were talking earlier, pulmonary arterial hypertension is a mean PA pressure of greater than 20, wedge of less than 15, and a PVR that's elevated greater than 3. Pulmonary venous hypertension means that there's passive increase in the pulmonary pressures, generally due to left-sided heart disease. You'll also get an elevated PA pressure, but that'll be accompanied by a high wedge pressure and low pulmonary vascular resistance. If you have both pre and post capillary pulmonary hypertension, you'll have an elevated mean PA pressure as well as an elevated wedge pressure and elevated PVR. I think I'll stop over here because it's 3 o'clock and take any questions.
Thank you so much for that, Dr. Singhvi, and going through all that. If anyone has any questions, you can feel free to unmute yourself or post it on the chat.
Okay. So to summarize everything, remember the indications for right heart cath. Look at the waveforms in addition to the actual numbers. Know that the cardiac output that you're getting by FIC is always limited by your assumed oxygen consumption. Ohm's law to calculate resistance. And hemodynamics do have a prognostic value and may be useful to guide therapy. And these are my references.